Dr. Rios, you do have the floor. Please go ahead.
Buenas tardes con todos. Gracias por la invitación. En realidad para nosotros es importante compartir la experiencia del Perú, tanto en el manejo de los pacientes
Experience
XDR y XDR que están recibiendo esquemas con las nuevas
management
drogas,
of the ambulatory treatment for the
y también
XDR
lo que hemos implementado en estos meses de pandemia
treatment with the
a
drugs. And
raíz
throughout this
de la el aislamiento social obligatorio que tuvo el país por
due
varios meses,
to the
como 4
mandatory
meses, y una serie de
lockdown
cambios que
that
se
we had
dieron
for
en
4
el
months and
entorno de
several
la pandemia,
changes
y
that
que
we
nos ha
had because
hecho
of the
reflexionar y
pandemic
ver de que hay otras formas y otras
that
modalidades de
had
tratamiento que podemos
made us
nosotros
think about
perfectamente
new modality treatments that
eh, implementar para
we can
futuro, ¿no?
implement
Bueno,
in the
la
future.
siguiente, por favor.
Next slide.
Este es nuestro mapa epidemiológico de
This
tuberculosis.
is the
Como ustedes
epidemiologic
saben, el Perú
situations
es
for
el segundo
TB.
en
Peru, as you
las
know,
Américas
it's
en el
the
número de
second
casos de
country
TB en
in the
general,
region of the
en general,
Americas
y somos el primer
in the number of
país
cases,
que
and we
reporta
are
la
the
mayor cantidad de
first
casos de TB, MDR y
country
XDR.
to
Esto va de la
report
mano que el
the
país
highest
ahora
number of
sí
cases,
ha
MDR and
incrementado sus
XDR.
métodos
And
diagnósticos,
in our
tanto
country, we have increased our
los
diagnostic
convencionales
methods,
como los rápidos, para hacer
both the
el
conventional and
diagnóstico
the
de
quick tests,
tuberculosis
so that
resistente a
we
rifampicina,
can
multirogo
perform the
resistente, que tenemos
diagnosis of
protocolos
MDR,
para
tuberculosis, and
tuberculosis. Entonces, en el
RR-TB,
país
and also we
estamos
have quick
actualmente
tests
diagnosticando 30.000
to
casos al
diagnose
año
the
desde el año
XDR-TB. We've been
2018 hasta el año
diagnosis
2020, y implementamos
30,000 cases per year, and we've
una intervención
implemented a
buscando
plan, an
disminuir la brecha
intervention
diagnóstica
plan,
y llegar a la estimación
trying to
epidemiológica por la
decrease the
Organización Mundial de la Salud,
diagnostic gap.
a la par de tener
And
metas muy altas como llegar al 90% del
we
escalamiento de
had
contactos
very high goals,
con abandono y
90% of
tuberculosis sensible y
contacts,
tuberculosis resistente,
follow up, and
y
decrease the
esto
cases
para
of sensitive
este
tuberculosis and resistant
del
tuberculosis,
año
and
2019 recibimos
also
32.200
identify
casos de
the
TB,
diabetes and the
en el año
HIV.
2020.
We
Hemos
want to achieve
tenido
33,000 cases for
1.434 casos
2020,
de
and we've
tuberculosis
had
resistente, más o menos un
almost
5% más
1,500
de
cases of multi-resistant
eso viene de
tuberculosis and 89 of
está muy
XDR
equilibrado
tuberculosis. In our
cantidad de
in our
tuberculosos, sobre todo
country,
en grandes ciudades. En Lima y Callao,
TB is
Lima la mayor,
centered
y Callao la
in
segunda
the
ciudad
big
nacional.
cities, and
Está
Lima and
cerca
Callao.
a Lima, es uno de los puertos más importantes del
Callao
país.
is near
60%
Lima, one
el
of the most important
60%
ports
de
in
los
our
casos
country, and
de
there we have
TB en general,
60%
y
of the TB
tenemos
cases.
80% de los casos de MDR y 75% de los casos de XDR,
80% of
y
the
una tendencia
cases of
creciente
MDR and
muy
almost
importante
70% of the
la
cases
siguiente,
of XDR
la siguiente, por favor. Esta es
tuberculosis.
nuestra tasa de morbilidad en los
This
90 al
is
2013.
our
Lo único importante
morbidity
aquí es que a
rate as
partir del
from
2017
1990
cambiamos
to
de fuente de información. Tenemos un
2019.
sistema de
We have
información
a new
unificado muy fuerte en el
operational
país, donde da
informational
información al
report
instante de los
system, which is a very strong system, and it gives us all the information of the 7,000 or 8,000 health
Aquí un
institutions
poco
that
de
we have.
contexto
And what
desde
is
que
important
empezó
here, this is from
la
2018,
metodología del expert.
when we
Una
started with the
disminución
expert
en la
methodology,
tasa de
we
incidencia de
saw
casos
a
positivos.
decrease in the
Decíamos que la
incidence
tasa de
rate,
morbilidad se incrementó debido a la búsqueda activa en la que nos encontrábamos.
although the mobility rate was increased
La
because of the
siguiente,
active sea.
con respecto a la organización
Talking about
la organización
the
técnica del programa de
technical
tuberculosis en Perú,
organization of
nosotros
our
tenemos lo que
program
llamamos las
in
unidades especiales
Peru,
de tuberculosis,
we
que es
have the special
un
units of
hospital que ha sido capacitado,
tuberculosis,
que
which
en
are
todas las condiciones de
hospitals that have
apertura
been
y sobre todo
trained
en
and
este
have
plano para
all the
llevar a cabo el manejo
infrastructure and the
de
human resource
tuberculosis
needed for the management
resistente y
of
se van a
the
tratar
MDR
la
tuberculosis
tuberculosis
and
sensible con
XDR
manejo complejo,
tuberculosis, or
el
sensitive
asunto que
tuberculosis with a complex management.
médicos, lo que nosotros llamamos los médicos, los consultores
We have
intermedios, a la par
the
en cada
intermediate
una de las regiones del
consultants,
país.
which are the
Tenemos 25
physicians that
tenemos
are trained,
regionales
and
que
in the
evalúan los pacientes
25
con nuestros
regions in the
indicadores de
country,
tuberculosis
we have
resistente.
regional
Tenemos un comité de
committees to
evaluación de
assess our
requerimientos que
patients.
están en Lima,
we have the Retreatment Assessment Committee, which is centered in Lima. As you know, Lima has a vast population with 4 regions where they also have regional assessment committees. And we have the national committee where we refer all those cases that couldn't come to a solution in the regional committees and where all the XDR cases of tuberculosis are sent to the national committee for treatment. For XDR tuberculosis, we have 2 types of treatment, the IV and the oral treatment. In 2016, we started with the oral treatment with the bedaquiline addition. At the beginning, the medical community didn't want to use bedaquiline only the oral administration route, and they kept on using the IV administration until they got to know this medication. They had their own experience, and it showed that it didn't have such an amount of side effects as the other drugs that, for example, made a prolongation of the QT. So from February 2016 until now, most of the cases that come receive the oral scheme or the oral treatment, and the one with the IV administration that has imipenem, adenosine antiopenem. The 86 patients that we have per year are brought into Lima, where they get hospitalized, and whenever they need an IV treatment, they are kept in the hospitals in the intensive phase that can last between 8 months to 1 year, and after being at the hospital, they are treated as outpatients. In 2016, we started with this type of work. In the high-load regions, we have special teams trained for outpatients that have nurses and physicians that go to their houses, and they also have psychologists, nutritionists, social services are present there because we must give them a comprehensive treatment because these are really difficult patients and it's very difficult to maintain and to have compliance with the treatment for almost 2 years. And we try to avoid discontinuation in the treatment. The IV treatment has an intensive phase and then they have a continuation phase being treated as outpatient where they had to have negative cultures, and when the patients are recovered then they go back to the hospital where they receive their medication, stopping their treatment at home. The oral treatment has an intensive phase of 6 months where you include the bedaquiline, and then they have a continuation phase from 1 year to 1.5 years where there is an intensive phase which is where they receive treatment at home, and the team administers not only the treatment but also they check the possible side effects and the adverse reactions due to the treatment or psychological or social problems that more often than not are present in this type of patients. These 2 type of treatments, oral and IV, are accompanied sometimes of other drugs depending on the sensitivity of the patient. These treatment schemes, which are called treatments for XDR-TB and have been used for other type of patients, that are those which are with extended resistance or with MDR, and some other special cases which are assessed by the committees, cases that do not respond to treatment, and they are not XDR, they are pre-XDR, and the committee decides to start on this treatment. In the case of these special cases, they're assessed in the national committee, but if in a certain region there is a risk of a patient of dying because they didn't start the treatment, they start with the treatment, and in the following 30 days, we receive the information, and then we reassess the patient, and we decide whether to continue with the treatment or not. As I was telling you, the comprehensive care of the patient is our aim. This is done by the unit, which is a specialized unit, and this unit is going to be responsible of our patients, of this difficult patients with XDR or MDR, independently if they are hospitalized for the treatment or they continue the treatment at home with a special team. And every 3 months, besides the follow and the control with the treatment physician, they also have a consultation with the specialist. We also control the family. There is a lot of contact with the family, with the close contacts, because as you might remember, the treatment is given at the home of the patients. So the family also gets involved, and we also have personal psychologists to support our patients during this long treatment. This treatment, as I was telling you, with this treatment, we treated almost 1,000 cases in 7 years. I do not have the latest information because due to the pandemics, there is some information that has not been updated yet. And something important is that we are now centralizing the treatments. We want to decentralize the treatment so that the patient does not have to travel from one place to the other or come to Lima to receive the treatment. Now we are working on a pilot project to decentralize the treatment, and we are training all the treating physicians for that. This is all the cases that we have from 1999 to 2019 due to XDR tuberculosis, more than 1,000 cases, and 82% of the cases are concentrated in Lima and Callao. So they are concentrated in the large cities, as I mentioned before. This is the distribution that we have of all the cases. It started in Lima back in 1999, then it went to Callao, and then it got distributed in the different regions of the countries. But in some regions, we have only one or two cases, and the largest amount of cases are concentrated in the big cities, as I told you before. So when patients are unstable and they can go back home, then we refer them to institutions back home. To bring the patient to Lima, although we pay for the expensive and for travel expensive to they really have psychological problems because they are not surrounded by family, they're facing a very long treatment. And this is the cohort of XDR tuberculosis cases in this period of 7 years. This is a combination of these two schemes. By 2017, we had almost 70% success rate in treating our patients. We started with the IV administration route with the lasrilipiminem, and as from 2017, we started with the oral treatment. Comparing now in 2017 using the IV versus the oral administration route, we have more success with the oral administration. And to have available this oral treatment, centering the patient, being able to be treated at home, this is really very helpful because it avoids discontinuation of the treatment. Now, we think that this good experience and the same treatment scheme can be replicated and can be applied and given to people with XDR-TB. The success of the treatment has to do not only with the drugs, but also with the multidisciplinary approach with psychological support and the family near the patient. That is why we've started working in this operational research with the WHO and the PAHO so that we can include patients with all this logistics support that renders good results and is cost effective as we have analyzed. And we are thinking and started by January 2021, including rifampicin-resistant patients and multi-drug resistant patients with this new oral scheme. So what has been the impact and the response during these pandemics? I'll speed up a little bit now. We've been working with these 5 indicators that have been analyzed on a monthly basis by the whole team, the Minister of Health. We were able to collect cases of more than 850 patients for the management of tuberculosis in the high-risk areas, and these have served to improve the quality of attention of our patients, and we have also lost fewer patients in follow-up. As we give a better attention and we have trained team that can go to their homes to give them psychological and social support has been very helpful. So up to 2019, we have improved a lot in detection, and we were able to get almost to what was expected or desired as estimated. And when the pandemic started, this worsened a little bit. All the resistant cases, MDR, XDR, RR, we wanted to have as goal that none of the patients of this type of patients should be lost in the follow-up. We also improved in the number of evaluated close contacts and percentage of close contacts that were evaluated. The information system or the data collection system changed, and we had less reports throughout the last years. In our system, we have connected this data collection system to the ID, to the national ID, in order to avoid duplication of the data. We had a great improvement in the screening for coexistence with HIV, and this allowed us to determine that the first comorbidity in Peru, in our country, is diabetes, with a 10% is national average, whereas HIV is only 6%. Due to the pandemic, we have lowered the detection, and during the COVID-19 pandemic, we've detected fewer cases, due to the situation in Peru, and we were able to detect only 9,500 cases when compared to previous years. This showed a decrease in about 40% of detection. Discontinuations of treatment are not that great, but I am going to share with you the different modalities that we use to supervise the treatment. The percentages of close contacts also decreased in their assessment, and the screening for HIV we decreased from 94 to 85%, and the diabetes screening didn't decrease that much, only from 98 to 94%, because for the HIV, we didn't inform consent of the patient to perform the screening, and that was more difficult during the lockdown. Currently, we have two systems in Peru that we are interconnecting, the SysCodic, which is a nominal system where we have all the tests that we've been doing on a national level, and we are cross-linking this with another nominal system that we have. And out of our data collection system, 296 people had COVID symptoms and were screened.
Of them, of the 296, one behind place of the 296 cases that were screened, in 100, the TB was detected together with COVID infection, and of them, 96 were sensitive and the rest were drug resistant. We were able to assess the regions. We see the regions that have been more affected, and we see also the percent of lethality, the fatality rate in case of active TB with COVID, which is 4%, a little bit above the national average as a country. This information is being updated monthly since March the 16th, when Peru issued the decree because with the national emergency, and then we had the mandatory um, confinement. Then they started issuing various newsletters and statements, and we're now compiling all of these in a technical document. There was the ministry should resolution where they specified that all the first level health institutions had to make sure that the TB services were not interrupted, and that TB treatments were going to be administered through the three modalities that the program established, the those with family support, the institutional, and the home type. With these types, we have seen more than 15,000 patients with TB. Some of them had been entered this year, others came from last year. 4,924 patients were monitored with this, that with family support. In each family, one person was trained, and they received all the information in case there were adverse reactions. And that person would go every week to the institution to receive the medication. And as a minimum, 3 times a week, the nursing personnel would monitor the medication intake with video calls. We also have an institutional dots with for patients with injectable treatments. In many regions, they had these cases, but they put them together with XDR-TB. And in cases, for instance, of elderly adults and pregnant women, stayed home, but the others went to the healthcare establishment. Of them, we had 677 throughout the country. And those that continue with the home dot treatment are the XDR and pre-XDR patients who have home teams that have been maintained throughout the pandemic. and they do continue with that modality. Like I said, a total of 15,280 have been seen with the 3 modalities of treatment administration. We had to do this really quickly in order to guarantee that the patient would continue treatment. And we saw that the dot with family support works quite well. We are now close to approving an app because given the rush, we're doing this with video calls with the cell phones of the healthcare personnel, but we're almost at the point of finishing the app that we've been working on. And that is a video app that will allow the person to record a video, and when they have access to the internet, they will reach the cell phone or the computer of the nursing personnel, and they will report on the uh, treatment intake. We also assess the gap, loss to follow-ups, contacts, and HIV and diabetes screening per institution. And um, we had mandatory confinement until the end of July of this year. In August, we began implementing a plan which comprises mobile units that obtain X-rays and specimens. We started working on that since September 1st. The goal that we had was to screen daily 80 contacts, because it's not a general population screening, but rather a targeted screening to contact people living with HIV or diabetics or persons under diagnostic follow-up. They have an appointment where the campaign is announced, and they go through a certain circuit, which allows us to carry out a screening that is quite rapid of the contacts that were not screened during that period. There is a circuit that is pre-established. They wait for their turn. They come with an appointment and a certain time, because the mobile unit is installed maybe at a park or at a stadium or an open site, because the population is still very fearful of going to the healthcare establishments because of the risk of contagion of COVID. So we do that in open areas, as you see in the pictures. Then the contacts, we work all during the whole day, and we obtain X-rays, and we're working with the NGO that is lending us this card that has an X-ray team with software, special software that has been validated in a country for persons with TB older than age 55, and this allows us to assess whether the X-ray suggests TB or whether it's a normal X-ray. Those with a normal X-ray, the X-ray is printed, and then the person leaves the sample and sees the physician and then goes back home. We have also tablets given to the staff, and they have an app connected to our information system. So we have there the data of each patient, and if subsequently the resulting expert is obtained, then we go and search for the patient and give them treatment. Besides this radiological screening and the expert screening, we are applying, we are administering PPD, and the day of the campaign, it's red. Also, HIV screening is performed, and all the educational aspects on prevention of respiratory diseases, including TB and COVID. Until present, with intervention carried out during the first months, we had 20 mobile campaigns. We're doing this in Lima, which concentrates about 80% of MDR-TB in the country. So far, 110 institutions have participated. We've screened 1,894 persons. Of these, 894 were normal X-rays, and then the expert was detected with 6 cases that were detected with expert with a mycobacterium that was detected. Also, medical consultations were performed. And with this first intervention, we've been able to detect these cases. These are the cases that we've detected until now. Some are on diagnostic follow-up. We've detected 12 cases, and of them are expert positive and BK negative. That's very important because of the early beginning of treatment. And we've also began uh, 38 contacts. This group has been seen during this month. The system is actually, the intervention is very efficient. The morbidity rate is 634 cases per 100,000 inhabitants. For the regions that we've been assessing, the morbidity rate is 169 per 100,000. The difference here is that we're looking mainly at the vulnerable populations and the contacts, people living with HIV and diabetics, healthcare workers, former prison inmates. So this needs to be explained that this is the population that we're actually dealing with. This is the app that I mentioned that already has the approval by the Ministry of Health, and in these days this is going to be implemented. You can download it from Google Play. It's really very light. Even the simplest smartphones allow to download it, and then the patient can record the moment in which they take the medication and time and date, and when they have access to the internet, they can send us that recording. And also the app asks for adverse reactions, whether they have headache or whether they have other problems, and for that they have to attend the healthcare institution. Besides this newsletter on the methodology, we've also issued other statements. This was on March 21. Before other technical documents emerged, and I think that all of us who work in TB and infection control, we issue recommendations for the community. And in the case of patients, we were providing surgical masks so that they would wear them at home for the positive patients. So we've been providing those. Also, in the second statement, we had to modify some of the time frames because there was also a curfew. As of 8 p.m., no one could go out the street. So according to that, we had to explain how the patients who had to take the medication twice a day had to take them. We had to make recommendations for phase change and for discharge. In many areas, there was no access to X-rays. In patients with XDR-TB, we kept the indication for the patients to see their pneumonologist, and the electrocardiogram that was done periodically continued. And when there was no direct access, we carried out teleconsultations through the InfoSalud system that the Ministry of Health has. We also made recommendations for the areas of isolation. We have several specialized units in hospitals with isolation, with negative pressure and natural ventilation. When the epidemic began, we used those for COVID, and the patients that were hospitalized had to be removed from them. We also considered it was important to keep to a minimum the number of patients that had to be hospitalized because of the high risk of contagion of COVID. And so those patients were sent home and they started home treatment. Those patients were discharged from the hospital but followed at home. An important thing where the law of TB helps us is that they always mention the fact that the treatment is free of charge and the fact that we need to guarantee that treatments are completed 100%. And so together with the National Center for Procurement that brings together all the strategic drugs, and they're the center, the ones that actually purchased the TB treatments. We've worked together with them, and we had to do our task, which is programming and dispensing, but also we had to add another careful job with centers and the regional TB coordinators to see how procurement and storage and distribution were going, because as you know, there were a series of problems with deliveries of purchases through PAHO, and because borders were closed, there were manufacturers that were not manufacturing in time the TB medication. But fortunately, we had some regions that were still a little bit behind, but because of the pandemic, they all started using combined fixed doses. The individual doses, especially pyrazinamide and ethambutol, were left for some resistant TB cases. And we started doing an internal rotation between the healthcare in establishments and regions. And we also requested a loan. From a loan we had some NGOs have loaned us medication, and until on July 20, we had the delivery of the purchase made by PAHO, and then this became normalized. Fortunately, the regional storage areas sometimes were lacking medication, but we now saw in September the new deliveries, and we have been lending to other institutions. We had a lot of external rotation and internal rotation amongst regions, and we've also, some NGOs have helped us, and the health insurance, we have to ask them for clofazimine, but fortunately all our patients were able to continue treatment. And now we have complete supply of medication until 2021. These were the data I wanted to show you, and I'd like to tell you that the interventions that have been prioritized during the pandemic in Peru have been to guarantee that the TB treatment was continued seamlessly. All patients received, occasionally there were some problems, but we've had a lot of help from the organizations and the groups, and we were able to solve the problems like that. Sometimes it only meant that we had to transport the medication to areas where maybe there's just one or two patients. So we would send them the medication from the network. We were able to achieve that distribution throughout the country. This, in fact, has been for us sort of a change in our mindset, and understand that we had to make video calls or monitoring with the help of the healthcare personnel. Family support modality has been very important. Many families have really been very committed and supported their family members that were ill with TB. And another measure that was always was the actions in prisons where there were important outbreaks of COVID. And of the total of cases that we've had, of the 100 cases that we've had with TB and COVID, about half of them were in prisons. Fortunately, very few deaths until now. So this was improved thanks to the statements and bulletins that we issued. Thank you very much for your attention.